Hi, I'm Laurie Forner, and I'm a physiotherapist and PhD candidate at the University of Queensland. Today, I'm honored to present our preliminary analysis titled The Assessment in Standing of the Levator Hiatus with Transperineal Ultrasound in Vaginally Parous Females Who Lift Heavy Weight. This study has been funded by the Physiotherapy Research Foundation Seeding Grant. As female participation in strength training increases with the popularity of current fitness trends, so has the confusion regarding exercise advice for females, as increasing external loads increases the intra-abdominal pressure placed upon pelvic support structures, potentially increasing the risk for pelvic organ prolapse. Vaginal deliveries have long been one of the major risk factors for pelvic organ prolapse, and in part, this may be due to the structural and biomechanical changes to the levator ani muscle, which plays a role in both active and passive support to the pelvic organs. Though occupational heavy lifting has been associated with pelvic organ prolapse, we are lacking research examining the effects of heavy lifting within exercise. Therefore, the aim of our study was to compare measures of the levator hiatus in a standing position using transperineal ultrasound between vaginally parous females who lift heavy weight and those who are physically active but do not lift heavy weight for exercise. This preliminary study reports data from an ongoing cross-sectional observational study. Women were recruited if they'd had at least one vaginal delivery, were premenopausal, and were regularly physically active at least 3 times a week for the previous 6 months. They were recruited into 2 groups, those not lifting more than 15 kilos and those regularly lifting greater than 80% of their body weight. Women were excluded if they were pregnant, currently breastfeeding, had a chronic cough, and had any pelvic surgeries. All women filled out an online survey, which included general demographic questions and exercise history, and embedded within it was the pelvic floor distress inventory questionnaire. We used the question on the sensation of a vaginal lump or bulge to signify pelvic organ prolapse, and the question on the involuntary leakage of urine during coughing, sneezing, laughing, and exercise to represent stress urinary incontinence. 3D transperineal ultrasound volumes were acquired after bladder emptying using a Volucin eye system. Standing measures were used to observe the natural effects of gravity on levator ani support. Measurements included the levator hiatal area, which has been shown to be associated with pelvic organ prolapse, and the levator antero-posterior distance, which has been used as an ultrasound measure of pelvic floor muscle contraction. Levator hiatal area was measured in rendered volumes of 1 to 2 centimeters thickness in the plane of minimal hiatal dimensions at rest and on straining, also known as a valsalva. And major levator trauma was measured in supine during a pelvic floor muscle contraction using tomographic ultrasound imaging and was defined as the levator urethral gap of greater than or equal to 2.5 centimeters in all 3 central slices. Levator antero-posterior distance was measured from the most inferior margin of the pubic symphysis to the most medial margin of the puborectalis muscle. The proportional change from rest to maximum pelvic floor muscle contraction was also calculated. All measures were analyzed offline at a later date using 4DView software. We had 17 non-lifters and 16 heavy lifters participate in this part of the study. Heavy lifters were lifting anywhere from 50 to 120 kilos for a back squat, a median age of 39 and a median BMI of 22. Median number of vaginal deliveries were 2, heaviest baby 4 kilos, and 2 women in both groups reported the use of forceps during a delivery. 4 women in the non-lifting group were found to have a complete unilateral levator ani defect, whereas 2 women in both groups were found to have a partial unilateral levator ani defect. The percentage of pelvic organ prolapse symptoms are presented here and were smaller than the percentage of stress urinary incontinence symptoms reported. No significant differences were found between groups for any of these values. No significant differences were found for levator hiatal area at rest or straining in standing between women lifting heavy weights for exercise and those not lifting more than 15 kilos. Women lifting heavy weights did display a greater range of values for hiatal area measures despite no apparent major levator defect observed. Although women were coached on relaxing pelvic floor muscles during straining and all had undergone at least one vaginal delivery, levator coactivation was noted in some women in both groups, which could have obscured our findings. Hiatal area during straining has been shown to be strongly associated with pelvic organ mobility. Abnormal distensibility or ballooning of the levator hiatus has been defined at greater than or equal to 29 centimeters squared during straining in standing, in which a small number of our participants in both groups exceeded this cutoff. However, a larger population is required to confirm these findings. No significant differences were found between groups in measurements of the levator antero-posterior distance in standing at rest or on maximal pelvic floor muscle contraction, nor did we find any significant differences between groups in relative change from rest to maximum pelvic floor muscle contraction. To put some perspective on these values, while we lack normative data on the use of ultrasound to assess pelvic floor muscle contraction changes in standing, supine pelvic floor muscle contraction scales have been proposed based on the association with palpation and perineometry. A history of pelvic floor muscle training would most likely influence these values, but was not assessed in the study, and we cannot comment further on this population. These preliminary results suggest that some vaginally parous women who do lift heavy weights for exercise are able to do so without appearing to have an effect on the deep supportive pelvic floor musculature to an extent that differs from women who aren't lifting heavy weights. Obviously, individual variation in the complexity of pelvic floor support most likely plays a major role, and a larger population is required to confirm these findings as well as assess the effect on pelvic organ support. Thank you.